with chronic ankle instability. And I'll pass the mic.
A very good afternoon to everyone. My name is Adeline and this is Bala, and together we are going to present to you our final year project titled Correlation between Patient-Assessed Instruments and Clinical Measures of Ankle Function in Individuals with Chronic Ankle Instability. And this is a quick overview of our presentation. I believe that most of us here have experienced at least one ankle sprain in our lifetime. Pain, swelling, instability, functional limitations, and recurrent ankle sprains are some of the common symptoms that we may face. To summarize such clinical presentations, the term chronic ankle instability, abbreviated CAI, is used to classify subjects with recurrent ankle sprains and the subjective feeling of giving way. After suffering from a single episode of lateral ankle sprain, up to 31 to 40% of individuals report persistent symptoms such as those mentioned earlier. Now, let's take a look at the above case scenario. Mr. CAI is a patient who has had an unfortunate ankle sprain. From the subjective assessment conducted in the first session, it was noted that Mr. CAI has difficulty in running and complains of instability at times. On the second session, he reported that he now has slight difficulty in running with the ankle giving way occasionally. So, what exactly does instability at times and giving away occasionally signifies? Such information provided is based solely on the patient's perspective, and to the therapist, it is difficult to translate into information that can be interpreted objectively. Given current practices, such subjective information provided is vague and insufficient to accurately quantify and track the improvement and progress made in patients with ankle sprains. Hence, this is where standardized subjective scores need to come in to quantify improvements made based on patients' subjective complaints. The use of patient-assessed instruments will complement the use of clinical measures in providing a holistic clinical picture that addresses both the psychosocial and biomedical aspects of CAI. This is also in conjunction with the International Classification of Functioning, Disability and Health, also known as the ICF, which presents health problems in terms of impairments, disability, and participation problems. This ICF model is based in the context of chronic ankle instability. Using Venn diagrams, we will now attempt to illustrate the importance between these two types of measures. In the scenario that there is no relationship between them, as depicted by the two separate domains, it might imply that these two measures assess completely different areas. As such, the assumption that their joint use provides complementary information from both the patient's and clinician's perspective would be invalid. Similarly, if the two have so many overlapping domains as shown on the above, it would imply that they are highly predictive of each other. This would mean that at one improvement in one measure would definitely imply an improvement in the other. Thus, it would be redundant to conduct both measures. To the best of our knowledge, there have been no studies done to investigate the relationship between these two types of measures. With that being so, the aim of our study is to investigate the relationship between self-reported ankle function and functional performance in individuals with CAI. Self-reported function was evaluated using two patient-assessed instruments, Ankle Joint Functional Assessment Tool and Foot and Ankle Disability Index, and functional performance evaluated using the Modified Star Excursion Balance Test. The rationale of choosing these instruments will be explained shortly after. And for the hypothesis, there is a clinically significant relationship between self-reported ankle function and functional performance in individuals with CAI. Through this study, our group wishes to provide evidence to support or dismiss the joint use of these two types of measures, and hopefully to also provide directions for future studies to identify or to develop the most suitable outcome measure in evaluating individuals with CAI. Coming to the methodology, 74 student volunteers were recruited from the School of Allied Health from Nanyang Polytechnic. After screening of questionnaire, via questionnaire, 55 subjects were excluded based on the inclusion and exclusion criteria. The data was then collated and statistical analysis was done. The inclusion and exclusion criteria are as follows. For the patient assessed instruments, we carried out 2 questionnaires. The first questionnaire will be the Ankle Joint Functional Assessment 2, abbreviated AJFAT. The AJFAT contains questions related to impairments, disabilities, participation problems, and quality of life. It has been validated in assessing disability in CAI with excellent test reliability of ICC value 0.94. This is a sample of the question in AJFAT. For example, in question 1, how would you describe the level of pain you experience in your ankle? There are 5 options to which the subjects can choose, which most aptly describe their experience. The second questionnaire will be the Foot and Ankle Disability Index, abbreviated FADI, which addresses performances in various activities of living. The FADI is reliable in detecting functional limitations in CAI with ICC value of 0.89 and sound content validity. This is a sample of a question in the FADI. For example, for the task of walking upstairs, the subjects are supposed to rate the level of difficulty they faced. Next, for clinical measures, we are going to carry out the modified version of the Star Excursion Balance Test, abbreviated SEBT. The SEBT is a viable alternative to the gold standard of using force plates. Not only is the SEBT simple and cheap to carry out, but also highly reliable and sensitive in detecting any functional performance deficits with good intra- and inter-tester reliability. This is how the test map of the modified version looks like. Our group has decided to use 3 directions, specifically anterior-medial, medial, and posterior-medial instead of the original 8 directions, as these 3 directions have shown to be sufficient in detecting any functional performances deficits. And the subjects are supposed to reach as far as possible in 3 different directions for each foot, as shown above. Next up, Bala will share with us the results, the discussion, and the conclusion of our study. Thank you.
Thank you, Ellen. A very good afternoon to one and all. After the tabulation of the results, we arrived at 3 significant findings. Moderate correlations were found between the posterior medial ridge of the Star Excursion Balance Test and the Ankle Joint Functional Assessment tool, as well as the posterior medial ridge of the Star Excursion Balance Test and the Foot and Ankle Disability Index, with R values of 0.690 and 0.578 respectively. There is also a moderate correlation between the AJFAT and the FADI, with R values of 0.523. All results were proven significant with p-values of less than 0.05. Therefore, as shown in our findings, the posterior medial ridge of the SEBT was found to be the only excursion direction that had a statistically significant correlations with the patient-assessed instruments. This concurs with previous findings that the posterior medial ridge direction was the most representative of any functional performance deficits in individuals with chronic ankle disability. Through the findings as mentioned, the null hypothesis is therefore rejected. The hypothesis stands true that there is a clinically significant relationship between the self-reported ankle function and the functional performance in individuals with chronic ankle disability. It should be noted that the correlation is only significant in the posterior medial ridge direction of the Star Excursion Balance Test. Coming to the discussion, the correlations between posterior medial ridge of the Star Excursion Balance Test and AJFAT was noted to be stronger compared to the FADI. This could be attributed to the larger percentage of sedentary subjects, 63.2% in the study population. These subjects may not have taken part in higher level activities such as going uphill, as stated in the FADI. As such, their ankles may not have been subject to the same amount of stress, contributing to possible inaccuracies. Moving on to the clinical implications of the findings, it shows that there is a positive and moderate correlations between the measures. As depicted by the shaded area in the Venn diagram, the overlapping domains of the 2 measures imply they do not conflict each other, but still insufficiently strong to be predictive of one another. This result supports the notion that the joint usage of the 2 measures will provide more information on evaluating the function of one's ankle. The diagram above attempts to illustrate the components of both the subjective and the objective measurements. It has been shown in previous large-scale studies that these patient-assessed instruments quantify pain, swelling, instability, and functional limitation, and that the star excursion balance test will be able to quantify posture control, strength, range of motion, proprioception, and function of the other limb. The overlap region of the two domains therefore represents the functional performance of the ankle. Even with the best of studies, there are bound to be limitations and areas of improvement. Our first limitations would be the relatively small sample size. This is due to the strict inclusion and exclusion criteria, which only resulted in 19 out of 74 subjects being recruited. This then has the implication on the statistical significance and generalizability of the results, and hence, results should be interpreted with caution. Another limitation is the disproportionate number of subjects in each gender. Our study was made up of 5 males and 14 females. Subjects were also predominantly sedentary, with 63.2% not engaging in regular physical activity, according to the American College of Sports Medicine recommendation. This limits the generalizability of the results yet again. Lastly, there appears to be a ceiling effect in the patient-assessed instrument, especially FADI. Almost all subjects attain full score for the impairment-related questions in the patient-assessed instruments. This limits the sensitivity of the instruments in detecting differences between subjects with varying degree of functional limitation and disability. Given more time and resources, large-scale studies with a better distribution of subjects would be done to further substantiate our results. To conclude, this is the first study done to investigate the relationship between patient-assessed instrument and clinical measures for individuals with chronic ankle instability. Current findings provide preliminary evidence for the joint usage of both outcome measures in individuals with chronic ankle instability. Further research is warranted to provide more concrete evidence to support evidence-based practice of this new concept. Hopefully, the findings of our study will prove as a stepping stone in allowing clinicians to recognize the importance of both patient-assessed instruments and clinical measures in evaluating individuals with chronic ankle instability. And these are references. Thank you.